Hello, this is Cindy Kraft, and with me today is Dee Cornetti, and we are very excited to be here with you today for one of 3 webinars. And I'm pretty sure just the thought of that has many of you going, oh, really? That's a lot of time we're going to have to listen. Our goal is to make this both interactive and useful. Because we know that, especially when you see the D word in the title, and I'm not talking about Dee's name, I'm talking about documentation, that's a pretty quick way to kill off a conversation. People do not become clinicians because they want to document. If documentation was a passion, we'd have become writers. We would have not become therapists or nurses. We became these things because we wanted to help people. And along the way, you know, documentation started to become an issue, and what we learned was we had to write things down because we wanted to get good grades in those classes so that we could get out and help people. And then we went on our first clinicals and our first jobs, and people told us, you got to write stuff, and we're like, okay, I'm writing stuff. And then they'd say, well, I like it that way, or I don't. And then we would change, and then somebody else would look at it and say, well, I don't like it that way, I write it this way, or why do you write so much, or why do you write so little? And I think what happened is we got out the gate with a very dysfunctional relationship with the idea of documentation, as if patient care and documentation are 2 separate things, when really they are very much intertwined. The idea of us documenting is not about getting a grade. It's not about getting paid. It is about taking credit for what we do, because it allows others to see inside our head in relation to not just tasks getting done, but the decisioning behind it. And before you say, well, I don't think anybody needs to be looking in my head, well, if we're going to be requesting any sort of payment from a third party, they have the right to establish rules. I would argue that if you suddenly became Medicare all by yourself, and I'll even make it easy, let's just say you have an unlimited budget, so you're not even worried about what health care costs. If I came to you and said, I'm being nice, I'm helping people, here's my bill, you might pay me the first couple times because you're feeling generous and you got all this money. But if I was coming back to you day after day, week after week with kind of a, hey, I'm nice, pay me, at some point, you're going to reach a level where you go, I wonder what she's doing. I mean, I'm not saying she's terrible. It's not an adversarial issue. I'm happy to pay for this, but I'd kind of like to know what's going on. That's what documentation is for. It's not an intrusive, they're spying on us, but we have to figure out how to make peace with it, because either our apathy or our animosity makes us less than effective. And makes us generate documentation that over the course of all 3 sessions, you're going to hear Dee and I talk about things we've seen in notes. I want to clarify from the jump, we aren't making those up. I wish we were. We're not. These are things that we use as examples as a wake-up call to say we know people are delivering good care. But if it was being matched in the documentation the way it needed to be, we wouldn't be seeing issues of denials or targeted probe and educate or people up in the charts threatening to take money back. We have to figure out what we're going to do to make sure our documentation is efficient and effective. And what you're going to learn about Dee and I really quick is we're not slide readers, okay? We've all been to those presentations where you go, oh, please, please make this end. I can read. There's information in your handout that's there for you to refer to. It guides us through the conversation. There's nothing that we're going to put up on this webinar that you don't have in your handout. But we're not going to read to you. You have the objectives there in front of you. We want to focus in on how do we make this more than a conversation we sit through, go, yeah, I know, and walk away and still put ourselves at risk from a documentation standpoint. So in order for this to be interactive, we have the Q&A box open throughout the presentation. If you have a question, a comment, something you would like clarified about today's topic, please go ahead and shoot that into the Q&A box. Dee and I look at that throughout the presentation. If it's a question that makes sense right at that moment, we have been known to pull them in right away and address them. There's times I've interrupted Dee by reading stuff coming in on the question box. We've both learned how to work with that. If it's something where we're running into a time issue, and it makes more sense to put it at the end, we will address it at the end. But please don't feel like you have to wait till someone says, now is Q&A time for you to type something in. Those of you listening to the recorded version, rest assured, one thing, you can't use the Q&A box, but you do have email addresses. You all have our email addresses at the end of your handout as well as the end of this presentation. So if you need to use that to communicate a question or comment, please feel free to do so. So without further ado, let's focus on what is our content in this particular webinar. And we are going back to some pretty basic issues in relation to, I think sometimes we get very tied up in our clinical expertise. We are very much into the therapy weeds, as it were, about therapy interventions and techniques and different patient groups and exciting stories of how we've managed our patient and the complicated patients. That's not our conversation here. Our conversation here is sometimes we can be so far in the weeds, we lose track of some of the fundamentals that are specific to the setting that we practice in. And every setting has those fundamental requirements. Every setting has those in place. And so when I hear things like, they're a great therapist, they just don't document well. They're a great therapist, but they don't understand it. We can't really be comfortable ourselves by saying, yeah, I'm a great clinician, I really don't care about the rest of it. You have to care. You have to understand what those rules are. And when we're looking at home health in particular, there's this term, qualifying criteria. Many of us hear these terms more often than not in orientation. When you hear 50,000 other terms that create the language that is spoken in home care. But unfortunately, a lot of times we don't revisit that. And so we think it's all mastered from the get-go that, yep, I went through orientation and everything's been great. But so much information has to be digested over your tenure in home care. And at times, orientation was, a while ago. And some of this stuff may slip. And unfortunately, they may be things we know in our head, but if they're not manifesting themselves in the documentation, they can be things that get us in trouble on third-party review. Qualifying criteria is a big one, okay? What we have to understand about this term qualifying criteria is these are basically the requirements in place for the patient to receive services in their home under the Medicare Part A home health benefit. This is not specific to any therapy interventions or nursing skills that are needed. This is the starting point because you can encounter patients that absolutely need therapy, but they don't qualify to have it in their home. So we have to look at what is that baseline? What are those things that have to be in place to even have a discussion about providing skilled services in this particular setting? The large buckets for these are the patient has to require a need for intermittent nursing. They specify intermittent nursing because we're not built to be, 24/7 nursing services as Medicare Part A home health. We're not. So the language is very clear about it being intermittent. Or they need a need for physical therapy or speech-language pathology to open an episode of care. This is why when we look at the OASIS requirements around a start of care, it reinforces that if nursing is ordered as part of this, they have to do the admission. But if nursing is not part of the plan of care, PT and speech, either one can do the admission. Occupational therapy cannot. That's a whole other conversation that has nothing to do with they're not skilled enough to do so. It's a regulatory technicality. But once a patient has been established as needing intermittent nursing or PT or speech, OT is more than welcome to join the party. And if everybody else leaves and there's still a reason for OT, that can qualify them on a continued need for OT basis. But that's not the only thing. Homebound is a big one, and we're going to spend some time on that today because, as we said, you can need therapy but not get it at home because you don't qualify. So homebound status is a big one. The other one has to do with under the care of a physician. And under a care of a physician has taken on kind of a whole new level in relation to some recent regulatory issues in our setting. The idea that, the order, I remember when it wasn't all that unusual that the order basically just said home care. Didn't even bother to tell you what was going on with the patient or what services they wanted. It just said home care. And I always took that to mean it might as well just say, give them whatever you got to give them so they don't call me back, signed the doctor. Okay? We recognize that that's not really physician engagement in a care plan any more than just sending them an order and they send it back signed. Do they even read it? Are they directing the care? And this is not, please, this is not us saying we can't do anything unless the doctor tells us because we don't know what we're doing. No, it's not the doctor knows more than the home care team, but we need to show that the physician is participating. And there have been issues in our history of patients being ordered to home care, and out goes the admitting nurse to see them, and there's this big old wound and everything else, and this patient hasn't seen the doctor in over a year. So call the doctor. The doctor's like, well, I don't know what that is. I haven't seen him. What do you think it is? Well, wait a minute. There are roles and responsibilities for each of the disciplines. And so what we saw come into play recently was this face-to-face requirement that put parameters from a regulatory sense around this issue, that we can't have doctors just ordering home care on patients they haven't seen in forever, in some cases met for like 5 minutes and didn't really do much of anything with, and that we need to see that there is some intentionality on the part of the physician as to what needs to happen in home care. Not a dictatorial, I'm going to tell you exactly what you all have to do on every single visit and all of this business, but it can't just be home health and then I walk away from it. Many people don't understand is that a physician can bill and be paid for oversight of that care plan for home health. And so there's an added layer from the payer side that says, wait a minute, if I'm going to pay you for this oversight, I want to see actual evidence of oversight. Not just, your name on it, but where's that information that really speaks to a knowledge of what's been going on with this patient and a handoff to home care that feels more like a handoff partnership than a dump job. But Dee, trying to make that connection and say, well, that's interesting, but, isn't that the office? I mean, what does that have to do with me as a therapist? They're getting the referral. They're spitting out the 485. Why is this even up for discussion at the frontline clinician level?
Well, I think this is where operationalization comes in, Cindy, to be very honest. There has to be that connection between that intentionality of the physician order related to the need for home care at this time with this patient, whether they come from their office or they come from the hospital or they spent time in another inpatient post-acute setting, whatever it is. And this is what we need to work towards capturing and demonstrating in that those admissions or those initial assessments with our patients. And so our documentation still should support, okay, here was the referral information. Let's tie it to that rationale for care, what we're seeing when we get to with that unique patient, that individualized home situation, and how they're presenting to us. And so a role of the narrative or the part of that comprehensive assessment and those supportive evaluations should be building that fluency between the physician referral and the intake or the start of care, and building that interdisciplinary care plan for the patient. So if we look at someone like Mr. Jones, who was in the hospital after he, with recent onset pneumonia, COPD, antibiotics, he's new on oxygen, and he's been sent home with therapies after. And, and it could be nursing as well. The question is, what kind of information would you like to see documented as a reviewer, looking at the quality of the record and starting to build this continuity of care in the language, in the documentation that can follow this patient through their course of care? And so the best way that I've learned to do it as a reviewer and as a frontline clinician and as someone who teaches it and as someone who had an agency and had to defend these kind of cases is to simply ask certain questions or queries. And so this might be a way to start to identify in your medical record, whatever your system, your software platform, or your paper-based system is, status of medical conditions. So where are they in these conditions that led up to maybe the hospitalization, or why are they now being seen for home care along the course of this care plan, right? Along the course of recovering from this or dealing with these chronic diseases. What is that unique presentation of the patient at the time of assessment that only you, with your trained eyes, can put on the patient in that home setting where they have to function that is unlike any other setting because it's not standardized. It's not an inpatient setting. The environment is not controlled. We don't have staffing ratios regardless of what room you're assigned in the skilled nursing or the hospital. referral, right? We don't have that. We have a patient who may or may not have a supportive home environment and a support system and personnel in place that are reliable and capable of assisting them once they come home. And so we have to capture that. What is their current baseline? What are those impairments that are being realized from this event that led to the referral by the physician? What are the current subjective complaints of the family, of the power of attorney, of the representatives, of the caregivers, of the patient themselves? Okay, and what are those functional limitations unique to the patient? So they have deficits in certain areas. This is what they're saying is a problem or of concern to them. And when we do our skilled evaluations and assessments and we capture objective information, we should be tying it to how it impacts that unique patient and their function in the home. All right, so that's how we start to build that fluency. So thinking about it, we still have some other eligibility requirements. The next one is homebound, which you really emphasized and have teed me up really well on this, Cindy. And so we know that physicians struggle to really capture homeboundedness, but no one's going to be in that patient's home and see why these services need to be brought to them because they're unable to get out. Okay, and so rather than leave it very ambiguous, Medicare has gone through revisions and refinements, if you will, so that we have a very clear understanding of what are those elements that we need to be able to operationalize or capture. You know, again, like you said, just because they need a service, they need nursing, they need therapy care, does not mean that it has to be provided to them in their home under the Part A benefit. And so we have to go about establishing those requirements. And so Medicare has given us some language. They've given us some guidance. And what we've done as an industry, shame on us overall, honestly, from the records that I read in general, is that we're taking the language they give us and we're saying, yes, they have that. Yes, they have considerable and taxing effort. Okay? Yes, they get out infrequently. Well, that's not demonstrating how that's manifested for that patient. Simply using arbitrary phrases that we maybe have in a checkbox format in an EMR is not sufficient. You know, what's most interesting is Cindy and I read records where one of the checkboxes is the patient cannot ambulate more than 10 feet. That's checked by the admission nurse, and that same afternoon, the therapist goes out and says that the patient is able to walk 50 feet. And we'll see that throughout the course of care. And it's just like, wait a minute, you just said they couldn't walk 10 feet and you're measuring a different distance. Not that it's distance defined. The idea is that these arbitrary prescribed options for trying to define that homeboundedness is really not going to work in an individualized patient-centered care plan under the new COPs. Okay, we have to start to get to very specific things related to that patient. And this idea that we can use these non-quantifiable sort of expert observation where the patient has poor endurance or they fatigue easily. Listen, you know, sometimes depending upon what I'm doing, I can fatigue easily, but that doesn't make me homebound. And so we have to be very, very clear that we're speaking to the criteria that have been established by CMS. And this is well published in the Medicare Learning Network. There's very good guidance on this, but it's all throughout the regulatory findings. So let's go ahead and talk about how it's been broken down for us and giving us very clear instruction of the areas where we can start to speak to these items. So we have two criteria for homebound. Everybody knows that. We see it in our EMR. The first criteria is because they have an illness or an injury. They have some sort of need for reliance on external assistance or devices, right? So it's a physical limitation. Or without that, it could be where it's medically contraindicated for them to go out. So it's either or in condition one. So we establish that it's a physical reason or it's medically restricted for this person. And then once we establish that, and that is not simply based on a list of diagnoses or conditions, but that does support it, we have to go on and look at criteria two. And this is not an either or, this is an and. And this is where we get that terminology we see very frequently and we put a check next to in our EMR. There must be a normal inability to leave the home, and leaving the home must require a considerable and taxing effort. And so how do we operationalize that? Well, let's start by breaking down criteria one. Because of that physical reason, okay? So what would you look to be included in your documentation, or what should you try to establish? Well, first of all, the diagnoses can be relevant. Their acuity, their exacerbation level, okay? And what kind of assistance and to what degree. That's great. If it's a condition where it's contraindicated, this should really be supported by physician documentation, whether they're infection precautions, immunosuppression issues, or there might be psychosocial issues documented that we can support in our documentation as well. Okay? And so this detailed description of why this is problematic for the patient is another way of trying to capture this. So simply putting, the patient is homebound because they have ovarian cancer. That doesn't hold water, right? The patient is homebound because they have CHF. There's patients with CHF that golf, that enter the community and are freely mobile in the community according to standards for community-dwelling elder population. We cannot simply rely on a list of diagnoses for this. And so trying to capture what it is specifically about how that patient's presenting is going to be critically important into reaffirming, yes, the home, they do need these services and they need them in the home. They are truly homebound. So let's go ahead and look at that other criteria, criteria 2. This is where we really get caught up. And as a therapist, I think this is my ace in a hole, right? I think this is my winning card. I could turn this card every time and win. But instead of quantifying and operationalizing it and defining how this infrequent, considerable, and taxing effort is manifested for this patient based on my thorough assessment, okay, whether I admit the patient or I go and do an additional evaluation after the nurse admits them, we simply just check these boxes as if that connection between I said that they're weak, therefore they can't get out, that doesn't hold water. And so consider the documentation when we're talking about this normal inability to leave the home. First of all, what was their normal ability? Simply to say independent without an assistive device is not sufficient. Okay, so we have to know what is normal for this patient. We have to know what they normally are able to do and where they are limited now. And we need to try to capture that and push them to that limit, if you will, tap into that, what they cannot go beyond safely, effectively, medically safely. Okay, you know, they're going to desaturate. Maybe Mr. Jones is going to desaturate and he can't walk and his gait becomes very unstable and or he can't access the steps without, you know, a fall risk and significant assistance to get in and out. Right? Whatever it is, we have to start to tie those pieces together. And then when we talk about considerable and taxing effort, we're looking for things, what does happen that makes it considerable and taxing? Simply using words to define themselves, I learned a long time ago. I believe it might have been 5th grade, maybe 6th grade, maybe earlier, but it was very early in my education that you can't use a word to define itself. And so if we're trying to say it's considerable and taxing, we can't just say it's considerable and taxing and think we've met that requirement. And so when we're talking about capturing that unique presentation of the patient, because as a therapist, I have maybe have many patients who desaturate, okay, with an exacerbation of their COPD with recent pneumonia. I may have many patients that have aerobic capacity deficits and lower extremity peripheral muscle weakness with underlying chronic disease and a bout of hospitalization that really just contributes to that established deconditioning that they're experiencing. But it's going to be specific to each patient in the setting in which they have to function. And so to capture that patient uniqueness, we really need to look as clinicians. And I know the physical therapists, occupational therapists, speech-language pathologists, according to our professional organization, right, the holy triumvirate of therapy, ASHA, AOTA, and APTA, we know and we have adopted this biopsychosocial model of looking at health and wellness within the contextual factors. And so what this basically means in the ICF model is that with these underlying conditions, diseases, disorders that our patients experience that impact their body function, right? Their cardiorespiratory system, right? Or their neurological system or their orthopedic system. And the structures, the joints, the muscles, okay? Lung capacity, the ability, their ability to increase their heart rate, the healthy heart in response to exertion to pump that blood to the peripheral muscle as oxygen, carrying the oxygen. Whatever it is, we have to take those limitations due to those underlying diseases, disorders, conditions, and look at how does this affect this patient's activity? How does it restrict this patient's participation in those normally occurring activities, those roles and responsibilities? Okay, that may be pretty consistent across the disease process to a certain extent. But then this is where that biopsychosocial model is wonderful, because then it looks at how is the environment factor into this? How does those personal factors, their motivation, their cognition, their quality of life, their social support system, and the viability of that support system, socioeconomic, social determinants of health. These are the kind of things that we have to try to capture and paint a picture. And I know it probably sounds like I don't have time to write a novella, Dee, on, this intro about the unique presentation of the patient. We don't need that. We simply need to take the facts and we need to tie it to individualized patient presentation, tie it to how it limits their function and their participation. So the best way to kind of go through this, and Cindy, I'm going to kind of pull you in with me on this, is to maybe do a quick knowledge assessment. So while we're doing this, think if you can come up with some of the answers. Here is our scenario. We're not going to read anything into it, but we have Mr. Jones, who you've already seen why he's been referred, spent 5 days in the hospital. He had an exacerbation of his late stage of COPD. He had a new onset of pneumonia that caused it. He had a bunch of change medications, both oral and inhaled, and he's now started on O2 at home. He uses a rolling walker upon discharge. The nurse did admit him, documents that he has dyspnea with minimal activity, has a productive cough and is generally pretty weak. And he's not able to get back, based on what we can glean from him, his representatives, caregivers, whatever, that he's doing his self-care and his basic homemaking at the level that he was prior to this hospitalization due to these conditions. But he does live alone, and he was previously able to do his basic laundry, shopping, drive himself to medical appointments, okay? So thinking about that, having a little bit better picture of Mr. Jones, what do you think Mr. Jones's homebound statement might include? And then the next thing that, Cindy, I want to ask you is what additional information would add that unique patient characteristics, what additional information would you add to support that homebound status? So let's start with that first question. Based on his presentation, what do you think his homebound statement should include? What are those relevant points that we want to capture and summarize for him?
Well, it looks like it would be a taxing effort to me.
Considerable and taxing.
That's right.
I love that about you, Cindy.
I think, there's some real things that he now has a piece of equipment that he wasn't using before. I'm questioning with his new use of oxygen, how effective that is in managing his dyspnea, as well as just dealing with the logistics of the tubing. We've got limited ambulation and self-care due to this dyspnea issue. I want to quantify that a little bit more. And he clearly was able to do much more before than he is now. So that departure from his normal and the addition of equipment would be elements I'd be looking for in his homebound status.
Okay, absolutely. I would tend to agree with you there. All right, so what additional information do you think will capture that unique presentation of this patient, of Mr. Jones, in his home setting to support homeboundedness?
Well, I think that I'd want a few more things quantified from a data standpoint, especially this activity. I think we can't really rely on, the dyspnea with minimal exertion is an OASIS response. So I'd want to have that measured a bit more in terms of, getting into aerobic capacity. And, really speaking to the fact that living alone is part of this issue.
Mhm.
I think he needs a higher level of function than someone who may have a very attentive and engaged caregiver who's doing these things. And I think I'd also want information about what his goals are in this, because his perspective on it is going to be important. He may be somebody who's going to say, yeah, I want to get back to what I was doing. I have no intention of going to assisted living. Or he may be somebody who goes, that's it, I'm done, this has been going bad for a while, and I don't think I can stay here anymore. I think we don't really have that in the name, rank, and serial number overview, but I think the patient specificity also needs to be kind of where he is in this before I just make assumptions that say, well, you lived alone before, you should be able to get back to that. Maybe he sees it differently.
Yeah, and if you think about it, this is where that ICF and those contextual factors come into play, because we all have those patients that have a very environmentally accessible home and a very strong support system. They have an entirely different looking care plan. What is Mr. Jones's home setup? I mean, he might do these things, but how safe and able is he to get around the house? All right, get around that environment. Well, we're trying to rebuild his strength and address this dyspnea and resolve this pneumonia, with this chronic underlying COPD that's been exacerbated with all these new med changes. That's it. And is there any social support for him? He might live alone, but he might have very reliable neighbors or friends or family that check in on him. And so the question is, we have to capture that contextual factor, because that could make or break a care plan. We all have those patients that if they had one good, reliable caregiver, even if it was once a week, it would look like an entirely different care plan. You all know those patients. You treat them on the regular. And then sometimes we have an entire family, generational assistance for other people, and you think that's part of the problem. They don't need to be helping them quite as much. And so from my perspective, these might be some of the things that you'd look to capture. And I just want to be very clear in this area. The only person that can paint that picture from a trained eye with good clinical judgment, understanding the eligibility or the coverage criteria in home care is you, the evaluating clinician. You're the one there. You're the one seeing it, sensing it, and evaluating it, right? And measuring it. And so something has to be done outside of checking considerable and taxing effort. All right, so hopefully that kind of gives you some ideas and some examples about how to operationalize these things. Cindy, I'm going to turn it back over to you, because I know this is a sweet spot for you when you're starting to talk about how do we support the use of therapy services, or any clinical service for that matter. What are those coverage criteria in home care?
Well, Dee, you hit on the key word there, and that is coverage criteria. They're not interchangeable with qualifying. We've established that qualifying criteria are what basically get you to have services in the home. But again, just because someone may meet the criteria of homebound, we still have to address, are specific disciplines warranted in this case? We have to speak to that. And these, nod to my sweet spot is, I guess I'm one of those weirdos that sleep with the regulations under their pillow. I guess that comes from a place of, yes, I am very passionate about clinical care, but I got burned more than once early on in my home health career by you have to do this, or you never do that, or we always do this, very authoritatively portrayed professionally as rules, only to find out those rules aren't real. And I think it's not an indictment of the people who teach us things, but it's a professional responsibility to be aware of what the rules are for your setting. If you change settings in the future, you would have to change what those criteria are. We need to be aware. We have a level of responsibility. So when we look at the Medicare Benefit Policy Manual specific to things around therapy, to say that this is skilled therapy, it must be reasonable and necessary for the treatment of the patient's illness or injury. We're going to deal with that a little bit more in detail over these webinars, because reasonable and necessary, we've all heard those two words, but what does that actually look like? And then we have to be very clear that the Benefit Policy Manual was forced to emphasize this point in the post-Jimmo versus Sebelius lawsuit situation, to be very clear that coverage of therapy services does not turn on whether or not the patient can improve. Okay? So when we're talking about a patient needing therapy, that need is not identified by whether or not you think they're going to improve. That if you think they're going to get better, then you can provide the therapy. If you don't think they're going to get better, you can't provide the therapy. I know that that's a bit of a challenge for some of us to think about how that presents itself, so we're going to touch on that point as well. When we look at this issue of these general principles that govern it, I think, as opposed to saying, oh, those are rules and rules are boring. Yeah, but there's some interesting word choices in here. It refers to us as having an inherent complexity of the service, such that it can be performed safely and effectively only by or under the general supervision of a skilled therapist. So they're saying therapy is a complex activity. We're the ones who get a little cavalier about it because we've been doing it for so long. It doesn't feel like it was that complicated, but nobody went and slept in a Holiday Inn last night and woke up a speech pathologist. I mean, we put a lot of work into mastering these skills. What the Medicare Benefit Policy Manual is saying, what you're doing needs to have to implement those skills. If someone else could do what you're doing, then it's not skilled therapy. And we're back to the reasonable and necessary comment. It has to make sense in the context of that patient, which is why these preamble issue around the contextual pieces is so critically important. We see it over and over, whether it's in this piece, whether it's in skilled, reasonable, and necessary, whether it's the conditions of participation specifically, the unique presentation of the patient is hammered over and over and over. And this is where if our documentation looks like every patient is basically the same, we get pushback in relation to how can you say this patient needs therapy when it looks like they always get the same therapy. It's the same frequency, same duration, same issues, same interventions. Doesn't seem to really be relevant what's actually wrong with a specific patient. Again, we are not saying you're providing the same care in every patient. We're saying our verbiage choices when we document sometimes portray things we didn't actually intend. And I want to be clear, our mantra when it comes to documentation is more is not the solution. Writing War and Peace is not the go-to plan. It is about writing specifically to the needs of the benefit that speak to your value. Now, for some of you, if you're not writing very much at all right now, it may physically be more words. But we can't just say we got to write more stuff. We have to write smarter, not a volume issue. We also know, we've all heard this rumor, there's a certain thing. If the patient, walks more than a certain number of feet or this happens or that happens, boom, we're going to get denied. Okay, their own payment manual says they can't do that. That you can't just take what we would refer to as a rule of thumb, some arbitrary single point in time and say, oh, that you said that word or you did this thing, boom, we don't have to pay for this. The issue is you have to look at, again, the assessment of each beneficiary's individual care needs. Dee and I are not repeating ourselves. The manuals repeat themselves. And anytime they repeat themselves, it is a key element we have to hone in on. What are we providing that shows the beneficiary's individual care needs? So yes, can we find situations that appear to be the patient was denied therapy because they walked too far? The issue is not the number. The issue is there wasn't anything else in the documentation speaking to the unique needs of this patient. It looked like they just walked further than they were when the PT met them. Well, what's the value in that? Without the context, you've left them with just a number. And when you leave them with just a number, they start picking on, well, that just seems to not be necessary anymore. Our reaction as a discipline, speaking to physical therapy specifically, has been, oh, well, then don't use certain numbers. That's not the issue. It is that larger contextual picture of the patient. Do we reflect that? And diagnosis, as Dee said, just listing diagnosis doesn't say anything. It doesn't really say anything about the patient in terms of how those diagnoses or combination of them are manifesting themselves for this particular patient. A diagnosis doesn't determine if you need skilled services, because there are plenty of people who have diabetes that do not need a nurse involved in their daily activities. They don't. And there's plenty of people who have diagnoses that don't need therapy. I mean, you can have Parkinson's and not need therapy. And many therapists, we will absolutely agree with that, because if we say, well, how much therapy would you do for the heart failure patient? We would go, whoa, it depends. It depends on what's going on. It depends, just saying heart failure isn't enough. That is absolutely true. But you also have to understand this is not a statement from the policy manual for only certain diagnoses. Because if diagnoses don't determine coverage, then a diagnosis of a knee replacement or a stroke are not a free pass to therapy coverage. They're not. If they were, we would never see denials on certain diagnoses, and yet we do. So the diagnosis is a relevant piece of information, but it's only the tip of the iceberg that allows us to say, what does that look like for this specific patient? And even when we describe what does it look like, then the issue remains, do you need a therapist to do something useful about this? What is my contribution going to be? So when we just see, past medical history is a laundry list of diagnoses, and sometimes that list is so long. I believe the phrase you used, Dee, is, they've listed everything since, they came from the womb. Okay, is that really painting a picture of what the reasoning is that this patient needs to have skilled services? How are we honing in on more than just regurgitating a list off the history and physical? When you dig deeper to the conditions of coverage, Dee and I have lumped them into three categories because this is where they tend to gravitate around. And the box over there on the left tends to be where we are the most comfortable because obviously as therapists, we know that our job is to go in there and restore function. Restorative approach to care. Any of you who've worked in a skilled nursing facility, don't drag it to restore. You're not in a skilled nursing facility. Restorative care under the Medicare Part A home health benefit for therapy is talking about our ability to utilize our skill set to get people back to or potentially a little better than their prior level of function. We know this. This is our comfort zone. But what we have to understand is for more than 20 years, there have been the other two criteria, and both of them are maintenance. So any discussion that says there's no maintenance in home care, we don't do maintenance, maintenance is a bad thing, maintenance is, wait a minute. Maintenance has been part of the benefit for 20 years. Why have we not seen more of it in home care? Well, a very real situation of our intermediaries, our reviewers, being allowed to deny us off of lack of improvement. This has happened in home health, it's happened in outpatient, it's happened in skilled nursing facilities, and in inpatient rehab. We've all had our hands slapped at one point or the other. How do I know this? Because of all the rules that have developed around it in our head. Things like plateaus are bad. If the patient has been seen X number of times without significant improvement, you have to discharge them. If you don't think they're going to get better, you can't see them. If you go out and evaluate them and you don't think they're going to get better, you do an eval only. Even though you gave them exercises, you recommended some equipment, you don't go back because you can't. Our resistance to maintenance is not because we don't care about patients. It's because we have practiced, many of us, our entire career in an environment that said you improve them or you get out. And our documentation reflects this, with an almost OCD level of trying to show improvement. Not to the point where we're talking about increasing half a grade. Ambulation is always going to increase in increments of 5 or 10 feet per visit. Nothing in between, always end in 5 or 0. Wait a minute. The coverage criteria state under Condition 2, the one in the middle, you have evaluated a patient, you do not see an opportunity to improve it, but you have a significant concern that if they are not given a program, equipment, recommendations, that they will decline unnecessarily. That if they don't have the skilled guidance of a therapist, this situation will not stay where it is. It has a significant risk of getting worse. This is why you're giving out exercise programs and making recommendations on eval onlys. You do it because you see a need. Condition 2 says go for it. But with that comes the responsibility of ensuring that the patient and or their caregiver or both are able to follow through with that program and that the program is effective. Not you need to come back to make sure they do it. You need to come back to make sure it's working, that it's the best program. You're a gifted therapist, but the idea that you can knock out a home program and hand it to them and never see them again, how risky is that in terms of does that even work for them? Doing a program and it working is not the same thing. Condition 2 says go back until you are confident that they have the most effective program possible. Condition 3 says there are going to be situations where you also do not expect improvement. You don't. But what this patient needs to have to stabilize requires a therapist to do it. You can't give it to somebody else. You can't give it to a caregiver. Based on the complexity of the patient and or the complexity of the therapy, only a trained therapist can do these maintenance interventions. Condition 1 allows us to use physical therapy assistance. We cannot use assistance, physical therapy assistance, occupational therapy assistance. We cannot use them under the maintenance criteria because of the level of decisioning. So if you're going, oh man, this is a whole bunch of, that might be an expanded conversation for another day. The point here is a stabilization approach to patient care is covered under the Medicare Part A home health benefit. What is not covered, regardless of if I'm trying to improve somebody or stabilize them, is I cannot, as a therapist, just do things with the patient because they don't have somebody else, or the person that they live with doesn't want to do it, or their caregiver is inconsistent about doing it. So I'm going to keep doing it. I can't discharge him because if I don't come, he won't do it. We have family members try that. If you don't come anymore, he will stop. That does not define skilled need. Never has and is not expected to in the foreseeable future. The question to ask yourself is actually simple. If what you're doing with this patient, someone materialized or the whole neighborhood showed up and said, teach me, would you say, good, I'm going to teach you. Once you're taught, you do it with them. I don't need to do it anymore. If that is the case, if you would comfortably teach someone else, then what you're doing isn't skilled. Someone else could do it. We're back to the complexity issue. This is why in our documentation, when we document that the patient is independent with their home program and then document that we've gone through the home program on the visit, the question is very easy. What for? If they're independent with it, you sitting there and counting and reminding does not take the education it requires to be a therapist to do that. If you are critiquing, providing feedback, updating the program, adjusting the program for effectiveness, that's skill, which is not captured in just giving us names and reps. That doesn't look like skill. That's counting to increments of 10. We learned to do that in elementary school. That doesn't take a therapy degree. We have to really look at this and cannot say, I'm going to provide care just because they live alone, because the wife doesn't. No, that does not make what you do skill. The other thing that kills us is when we document patients in an assisted living are walking down to meals with the staff, and then I come on a visit and I walk them down to the dining room. All right, if it looks like all I'm doing is walking them that day because the other guy wasn't there to walk them, if it's just walking people, again, does not take that level of education. We have to be speaking to, it took a skill set of a therapist to do these things. And Dee made this slide. I give her full props for it. It has led to some question as to whether or not she quilts. No, she does not quilt unless she's taken it up since our last webinar. But I think the visual is very good in showing that this maintenance approach to care, this stabilization effort, is complicated. It's the complexity of therapy. If it was easy and it was just going and reminding people to do their exercises, that is not skill. But building a program to determine if it's safe and effective, is it working for this patient, do I need to make adjustments, is this really going to work to prevent decline, do my test and measures indicate that this patient has stabilized, requires complexity, therefore does meet the criteria of skilled care. So we have a knowledge application exercise. So I want you to kind of take a second, look at the examples on the left, and I mean just look at them. Don't start reading in some other thing in there because I know 2 sentences or 1 sentence may not feel like enough information. But based on that snapshot, do these feel like restorative patients, maintenance patients someone else could follow through with the program and I am just overseeing versus patients I have to do the program? Starting at the top, we have a dementia patient with increased sedentary behavior for the last 3 months. The first thing we'd have to ask ourselves is, in my agency, would this patient even be referred to therapy? Because there's a very real reason they should be. The longer you sit, the longer you don't do, what are the risks? Pressure ulcer, immobility, other challenges. Does it take the skills of a therapist to create a program for someone with dementia to follow through on, and an appropriate program to manage their activity level? Yes. So what coverage criteria does that lean you toward? Do we expect to improve this patient Probably not. So out goes criteria 1. Do we think that we're going to have to see this patient 3 times a week for all eternity too? Probably not. That patient would lead toward coverage criteria number 2 in relation to the development and management of a program that someone else can follow through on with this individual. The second one, first of all, the minute you read it, you're probably thinking, yeah, I think that's speech. Yeah, I would agree with you, because you're talking about a patient with severe COPD, recurrent pneumonia, breathlessness, with eating and airway clearance deficits. All right. Again, fixable patient, back to a prior level of function. Nah, not feeling that. What about having somebody else follow through on this? Well, at least initially, if you're talking about we're having airway clearance deficits, breathlessness with eating, this sounds pretty darn complicated and not something that a layperson should really be all up in, at least at the very beginning. That manifests as coverage criteria number 3 in relation to, wait a second, this is probably going to take a therapist to do this with the patient for a period of time, and it wouldn't matter if half the neighborhood showed up and volunteered. A therapist and only a therapist can manage that level of care. The third example, exacerbation of CHF. Now you notice all 3 of these patients have chronic disease. We aren't doing the unfortunate reality of, well, maintenance is for ALS, Parkinson's, and progressive neurologic. No, there's no diagnosis that defines anything. It is, what do we think is this person's reasonable potential? And someone who has had an exacerbation of CHF, overloaded on fluid, got diuresed and in the hospital for 4 days, that person might have some potential because they were at a prior level of function. Something happened. They went to the hospital. They're coming back. They're not where they were. That fits more of our restorative therapy model. So we have the arrows provided to reinforce this. But what we want to be thinking about differently as therapists is I don't approach it with only one option that says you either have to get better or I can't see you. I can utilize the maintenance elements of the benefit, especially criteria 2, as that's the one we most frequently see, to create programs that other people are going to follow up on, but we need to periodically reevaluate the patient and the program to make sure it's effective. Our skill set is more than just getting people better. And when we look at our home health population, there's a lot of patients we could be of assistance with reducing rehospitalization rates by better managing their issues than waiting to see if the dementia patient declines functionally to the point he falls and breaks a hip. Oh, well, now we can provide therapy. Wait a minute, wouldn't it be better if we would have avoided it? And the severe COPD, well, there's not much we can do with that until they've aspirated themselves all full of pneumonia and go back to the hospital. And, oh, well, now we can have them back because now we can work on, could we prevent that from happening? So this idea of preventing decline is something we really need to become familiar with and comfortable with in managing the home health patient population. Because the fundamentals of defensibility, it doesn't matter if you think you're going to get them better or you are trying to make them stay the same. The issue is, what are those fundamental pieces? So when we look at this, we say, okay, what are they? Skilled, reasonable, and necessary. Oh, gosh. Then we say, well, what am I supposed to do with that? Those words aren't very useful. Well, I agree with you, and I like the icon, and I again give D props for the icon up there at the top of Yoda, because we have reached a point in this conversation that this is a do or do not. We can't keep just saying we're trying. We can't keep saying, I do create patient care, I just hate documentation, and this is kind of stupid, so just tell me what words to put down. No, we have to embrace our professional responsibility, and that starts with understanding skill. Skill belongs exclusively to you as the therapist. Skill is what you went to school for. It is all that time and all that money you spent in developing your proficiency. It was hard. Okay? Now, as you get more skill and spend more time, it doesn't feel as hard. You can't turn your therapy brain off. You notice things when you go out and about in the public that other people simply do not. And that's because you are a therapist in every cell in your body. You cannot get rid of it now. It is your proficiency. And when you understand that it's what you know, what you possess, what you've been trained to do, you also then have to realize that skill goes into the home with you and it leaves when you leave. If skill was something we could just give away, then at the end of an episode, a patient would say, wow, I'm now a physical therapist, an occupational therapist, and a speech-language pathologist. Yeah, no, you're not. You benefited from what I know. You didn't become one. So what does that look like when we talk about the need for a skilled care? In our documentation, when we talk about teaching and training, do we see that could only be done by the clinician? This is why ADL training or caregiver ed in and of themselves don't speak to this. Flipping over to the right side of the slide, swallowing techniques, therapeutic exercise, home exercise program. What is that? What specifically, why did a therapist have to tell you? I mean, if it really was just swallow, I could sit there as a physical therapist, look at you and say swallow. Now, I'm not trying to take away from the skills of a speech-language pathologist, but I am going to call it out in the documentation when it reads as though anybody could say that. Dee, you usually say this, but you gave me this slide, so I'm going to say it as well. I mean, when you read about bathe with verbal cues, okay, what was it? Like, go take a shower? Because I could do that as a PT. I don't need an OT to do that. I can say, go take a shower. Is that what you meant? No, that's not what I meant. We get all indignant. Yeah, okay, but this is how our documentation reads. Do we show that we are assessing the patient and reassessing not just the patient, did you do it, but what I gave you to do, is it working? How do I know those exercises are effective? How do I know that that piece of equipment is the right one for you? The problem is this goes on in our head on autopilot. We make program modifications, but we don't really put that down. We leave ambulation with walking, it's just distance, device, and level of assistance. We don't say what it is. We talk about ADL retraining, but we don't even bother to mention what those are. We're providing the great care, but it looks like it could be done by somebody else. This is why documentation is not a necessary evil, or if you didn't document it, you didn't do it. It is taking credit for how hard it is to be a therapist. That we have to step back and say, I know stuff other people don't. We write as though it's common sense. Well, duh, that walker was too high. Yeah, turn the wheels in, you can't get through the door. Yeah, if it was common sense, they would have figured that out before you got there. So we have to value ourselves enough to communicate what is skill. So let's do an example. Which of the following would you say, and Dee, I'm going to pull you in on this because you always pull me on these knowledge assessments. I'm going to turn the tables here. So which of the following would you say is not an example of defensible skilled therapy documentation? So we have the PT reviewed and modified the established home exercise program to include increased resistance by 3 pounds for the straight leg raise, terminal knee extension, increased to 12 reps in mini squats. PNF, the right lower.
I'm sorry. I was going to say, yeah. I mean, I see the patient, the PT involvement and what the PT did to that program, modifying it, based on the previous slide. I see that that's been met. So I would say that one meets it.
Okay, so if that meets it, then I'm done, right? Because usually multiple choice is one, and if it's A, then the rest of them must not be. But wait a minute. I mean, I try to read the second one, and I like when we use this example. No, I like the example when we read this one to nurses because they make a face. Because we start busting out PNF to the right lower extremity in D1 flexion pattern followed by pre-gait and progressive gait training on level surfaces to facilitate swing phase of gait cycle.
Well, that's just music to a PT's ears. I mean, I know exactly what that is. You do. Every PT knows what that is. I mean, that is demonstrating something only the intervention a qualified trained therapist could do.
Correct. But you and I have been reviewing charts together for 5 years now. I've never seen that. Ever.
I see gait training with verbal cues.
Yes. And see, OT provided, well, maybe, okay, we got PT covered. Maybe OT is the one messing up. OT provided patient and spouse instruction and use of resting left hand splint to include fitting device, doffing, wearing schedule, and integumentary check post-wear.
That sounds like some very specific education and setting up a program for a resting splint and follow through and specific training that they would have to get from somebody who knew how to train it, right? Fit the device, why to wear it, when to wear it, how to make sure it fits. That sounds right. So if I'm looking for one that can't be an example, then it must be D, right? But what does D say?
Oh, that's all we're left with. So let's look at it. A speech therapist advanced patient to mechanical soft diet and provided education to spouse caregiver in appropriate cueing of patient position during meals.
Yeah, I don't know that just anybody can decide that a patient is ready to advance to a different type of diet if they have dysphagia. So that would probably take the skills of a speech language pathologist in my mind.
Now, the
So,
issue, though, is these are kind of long sentences, longer than a checkbox, longer than a checkbox and 2 words. And I just said we don't advocate for more. So how do we reconcile it's not just an issue of more versus these 4 statements, which are clear that all of them are actually going to meet the criteria with respect to skill. But how would you reconcile someone, Dee, who says that's a lot of words and I don't need to write that much?
well, that alone would make that visit defensible from a skilled intervention. That would meet the skilled. That's it. Uh, in my mind, when I review charts, if I just put what my contribution was to the visit, and that's what I worked on, regardless of the 10 other things, just my contribution, what happened, what I participated in, then that's it. So think about all that other stuff that we write, all those sets and reps and distances and devices and all that gobbledygook that really doesn't account for anything. Those statements now don't look like that much because that ticks the skill box.
Well, would you like to lead us through the nursing example in relation to are we showing skilled documentation?
Sure. I mean, well, here's the same thing. Which one of these doesn't speak to nursing skill? I mean, we have instruction in hand washing and aseptic wound care for the prevention of infection during IV medication administration. I mean, I think we all know universal or standard precautions, but there's an entire contribution made by the nurse, right? And then the second one is the nurse instructed the patient and caregiver to set up the pill box. I'm trying to think what specifically required the nurse. But, we do pillbox setup. C, the nurse instructed the patient in dietary restrictions related to salt and fat content consistent with the American Diabetic Association recommendations. And of course, this would probably be tied to what kind of underlying conditions they have. So we're being very specific on the education of diet related to disease process management. That might meet it. And then nursing instructed the patient and caregiver in neuropathy, retinopathy, and nephropathy sequela of uncontrolled blood sugar levels with a newly diagnosed type 2 diabetic. So of all those 4, I think that 3 stand out as showing skilled expertise, the skill that nursing education and training would would be required to complete. Okay? I think 1 has the potential, but it doesn't speak specifically to that. So let's see if the audience got this one, Cindy. Go ahead and click through. It wasn't A is correct, D is correct, so it comes down to B and C. And the answer is B. B didn't really tick the box on showing defensibility of skill, now did it? Because it just said that the pill box was set up. So basically you took a box, you put the pills that you take once a day and Monday, Tuesday, Wednesday. When I think about it, there's so much more in setting up their medication schedule, but yet all we see documented is pill box setup for daily meds. That doesn't tick that box of saying, why did it take a nurse, a trained nurse to do that? Okay? Not talking about education on the meds, we're talking about setting up the pill box. So in these situations, we look at it and we say, are we really capturing what we're doing? And so really focus, try to get to those nuances of that kind of level of skill. Why did you have to fill up the pill box? Why couldn't the daughter or the grandson with the matching colors of pills put 1 purple, 1 blue, and 3 whites in each one of them? And we have to get a little deeper there.
And I appreciate those examples, Dee, because, many times people ask us for examples of documentation, and our hesitancy always is we've both had experiences in the past where we then had the opportunity to review people's documentation, and they basically used our example and cut and paste it forevermore into their notes. That's not what we're trying to do. We're trying to get us to think about this and say, if I read it, can I see why it took a therapist, why it took a nurse? Why me, why now is what we have to answer. And this is not an egomaniacal rah-rah thing about skill. It's owning that I'm the one with the expertise. The issue is, what was my contribution on the visit? And if some of our visits continue to read like we could have been outside peeking through the window while the patient does this, completes this, reviews that, that's where we get ourselves into trouble. And that then leads us into the issue of reasonable and necessary. So if skill belongs to me, then what is with these other two words? Well, reasonable has to do with, does the amount we're recommending make sense? Either the amount of visits or the interventions we're recommending, does this fit? Does it fit the specific needs of the patient? Does it fit with acceptable standards of practice? If I tell you that I'm recommending this patient have PT and OT 3 times a week for a whole cert period because I believe he can get back to taking care of his wife, his home, his pets. Currently he's bedbound, and he's been bedbound for 5 years. You can see the issue of reasonable. That doesn't mean there's a rule. You can't do that. There is a rationale that says if he's been in bed for 5 years, does it make sense? You think you're going to get him up and return him all to his prior level of function that far back? And based on what? So reasonable has to do with the fact, does this plan fit with this patient? Which is why if all of our stuff always looks the same interventions, no matter, these are just the plans for the diabetic, no matter which diabetic, it's the same interventions on the plan of care, really calls reasonable into question. And necessary is tied directly to skill. Because when we understand skill is what we know, what we possess, what's in our DNA now, then necessary is not, well, the patient has this diagnosis, or the patient fell, or the patient, has a lot of medications. That's not need. The need is, what do I know that is absolutely essential for this patient to either improve the situation or stabilize the situation? I have to show that what I did was essential, that I have a skill that they don't, and that if they didn't get this service, the outcome would have been different. So we very often get need tied up in, well, they have things wrong with them, and obviously if they have things wrong with them, there is no obviously. Things in our documentation to support reasonable and necessary look at, are our services consistent with the patient-specific situation? Do we see the unique needs of the patient reflected in this, and what is safe, specific, and effective under acceptable standards of practice? What unfortunately shows up more often in the documentation? Well, the nurse is going to do dressing changes and writes down in the same note that the daughter does the dressing changes in between visits. Well, if all you're doing is a dressing change and you already said the daughter's proficient in doing the same dressing change, then that's not skill. Yeah, but I'm doing other things. Well, where are the other things? Because if you don't create that full picture, as we said in the policy manual, they're going to nail it and say, you're the one who said the daughter can do it, let the daughter do it, that's free. Ongoing memory training, or I'd argue repeated recertification for more education to a patient in late stages of Alzheimer's. Are you really educating this individual? Because I'm pretty sure they're not going to remember. We're 3 certs in. I don't think they're going to get it. What actually is your strategy? Who are you actually teaching? When patients have advanced neurological conditions, we know the tertiary Parkinson's disease, this gait training that looks just like gait training in an orthopedic patient, as it's documented, doesn't make any sense. And always increasing walking distance. And I'm picking on PT because, one, I am one, but secondly, more importantly, physical therapy still represents about 75% of the total volume of therapy in home health. Thus, it's the biggest target. And the easiest thing to get hit on are all things gait related, which is why if it's just distance, device, and level of assistance, and I'm going to get you to walk more, we don't know where or why, but we're going to get you to walk more, doesn't support reasonable and necessary. And it doesn't get fixed by putting things like to a mailbox, to the kitchen at the end of it. What is the overall purpose? Does it make sense with the patient individual presentation? So, which of the following do we see as an example of defensible documentation of reasonable and necessary care? And this time, I'm going to give you a minute to read through it, think what you want the answer to be, and then we're going to show the answer. So we have 4 options. Take your opportunity, read through it. It's going to be silent because you don't want me humming or singing. Trust me, that would be a bad thing. But read through your options and see what you think it is, and then we'll show you the answer. All right, so which are the examples? So we're looking for if any of these are an example of reasonable and necessary care. Well, the only one over there that made the cut was OT providing energy conservation and pacing education for ADL completion in recent stage 3 heart failure exacerbation. Well, wait a minute. How come the others didn't make it? We know physical therapy does gait training post-stroke. Okay, but what you can't tell from that is how long ago was this stroke? How involved is the hemiplegia? Is there any reasonable expectation for this to improve with progressive gait training? Are we looking at compensatory strategies? What exactly makes sense? That one doesn't really hit it. Well, speech for speech fluency. Well, it says speech fluency in it. Obviously, it's due to dysarthria and aphasia, which doesn't give us a contextual issue of where they are with those conditions, what you expect from those conditions, what's the severity of those conditions, what is speech going to provide, as opposed to the example that did make the cut, which we're understanding the energy conservation and pacing education for what activity and where they are in the disease process. So we are not saying this is, the perfect standard, cut and paste it, use as is, but to get us to think about sometimes what we leave out is the critical piece that says, yes, this makes sense and was essential that a skilled person of this discipline was involved in this care plan. That's what we have to be able to hit. So digging a little bit deeper, Dee, I'm turning it back to you to address issues specific to the therapy assessment.
Okay, so at this point, I just wanted to let you guys know, and I know you're probably looking at the clock and saying, oh no, how are we going to have this level of detail? We're not, because we're not going to teach you how to be a therapist, how to be a nurse. You know that. We're going to overview some of these areas where you need to start to look a little deeper and conscientiously look at what your level of practice are you practicing the highest level of your license when you seek to turn in your documentation, when you want to complete that record of that visit, okay? And so there's some guidance that we have for this. But ultimately, I have never, and I'm just saying, if the coverage criteria or the service coverage for therapy and for nursing is skilled, reasonable, and necessary, that's what you need to speak to. That's where the meat of your documentation is. And once you capture those elements, everything else is extra. It paints the picture, provides color commentation. It can be very, very helpful in establishing that baseline or showing intentionality for modification or progress or stabilization or whatever you're doing. But ultimately, these other things are areas you need to pay attention to. Right? And so we had Transmittal 179. They came through with the Jim V. Sebelius and removal of the improvement standard. But Medicare took an opportunity to give us some enhanced guidance on appropriate documentation. So they know we're not getting it right. They know we're trying, but we're not hitting the mark. And so this is right out of that transmittal. It's now been embedded in Chapter 7, right? Home health services, Medicare Part A coverage of home health services. And they say the role of documentation is not skill in and of itself. It facilitates dissemination for claims that involve skilled care. And so since Medicare cannot go out and observe all these patients and see all the quality care we provide, they have to rely on the documentation of those services consistent with the established criteria. So this is how they make an affirmation that skilled care was in fact needed and received. When we fall short of that because we're not speaking, we're not operationalizing the eligibility requirements, why they needed skilled therapy, why this utilization of nursing, that's where we get into trouble. Now, they're not going to be prescriptive. Medicare has never, ever, ever been prescriptive, right? Because there's no possible way for them to give an example that's going to fit every patient in every possible situation. And so they're very specific when they say, we're not going to advocate for particular phraseology. We don't think that there's anything that we can say that is required or prerequisite for coverage. However, we're going to tell you what's not sufficient, right? And when things like patient tolerated treatment well, or continue with POC, or patient remains stable, these are generalized statements that really don't meet that requirement. So those kind of generalized phraseology that we put in our assessments or our plans, continue per POC, all right, patient making progress, does not ticked the box of showing why it required you, why it was reasonable with the presentation of that patient, and indispensable to them at this point to either stabilize them or improve function. And so we have to start to look at, where does this responsibility lie? Because it seems like it's a hot potato, right? It seems like we're being driven from the outside. We have all these regulatory requirements and all these payer sources, and now Dee and Cindy, just yapping in our ears this afternoon, and more to come. And I stop and I say, wait a minute. If you look at your code of ethics and standards of practice as a licensed physical therapist, a licensed occupational therapist, or the PT assistant, OT assistant, or a licensed speech language pathologist, medical social worker, licensed nurse, right? Registered nurse. We all have these standards of practice that we are required to maintain according to our licensure. These are not externally required. These are based on maintenance of our licensure. So when you think about where the responsibility lies for ensuring that we speak to third-party payer requirements, we can get all the guidance we want, but ultimately it comes down to licensure, not regulatory bodies, not agency policy, not Dee and Cindy. Okay? Think about when you affix your signature to your documentation, electronic or handwritten or however you do it on your tablet. That should be an attestation that you have met the requirements for billing of this visit as skilled, reasonable, and necessary under the Medicare home health benefit. And if you can't say that, then submitting it and allowing it to be billed falls more into the fraudulent arena than it does covered services. And so we have this obligation. Where do we get this information? I'm going to go back to the SOAP note. We have to pull up what a patient says to us. It's not just, did you have pain or didn't you? Do you have a complaint or don't you? What's going well, what's not since the last time I saw you? So capture that unique information of the patient. What about objective information? That should be standardized and validated. We should be objectively quantifying the impairments when those measures exist, using them. It is not simply enough to say endurance is poor, or patient is taking their medication incorrectly, or their blood pressure has dropped, or they've fallen 3 times, right? We need to know why that's happened. That's what takes our expertise. Is it a knowledge deficit? Is it a weakness? Have we measured it and quantified it? Okay, is it balance, pain? What is it? Pull those pieces together for our patients. And when we capture the unique presentation of the patient with those contextual factors, with their subjective reports and our objective data, we now have information to make a clinical assessment, right? And so I can't say it better than Margaret Fenot, who is a nurse, who said, clinical judgment is defined as the conclusion or enlightened opinion at which a clinician will arrive following a process of observation, reflection, analysis of observable or available information or data. Okay, so when we say the patient was independent without a device as a prior level, and then we turn around and we say endurance is poor and strength is within functional limits, and then we say that the patient needs 30 visits of therapy, that's not a very informed, enlightened decision, and it doesn't make sense. And so it really is all about our clinical judgment. We have to come to a clinical assessment that captures factual information and the unique presentation of the patient. And the only person with the trained eyes that can do it, that is standing there in that unique setting of the patient, is the clinician in home care. We can make assessments, we can simulate it in other post-acute settings. We can do all of that, but we have that unique perspective in home care. And so Medicare is very clear about who has to make that decision. Remember what Cindy said? It's the responsibility of the evaluating clinician. So when we see documentation, or you read documentation for patients you're not familiar with, and we say things like progressing towards goals, continues to require assistance with medications, tolerating well, No, still not independent with self-care. Whether or not they ever get to those levels or not is irrelevant. What is relevant when you are making a clinical assessment based on the factual and subjective information is, would that patient benefit from continued nursing or therapy services based on your professional judgment? Based on if it's a start of care, based on the baseline and what you know previously in the course of their medical conditions, based on what they've received so far, if it's a 30-day therapy reassessment or it's a 60-day reassessment of the patient. And we've had modifications and we've shown stabilization or plateauing, and the program and the patient is doing well in this situation. Or have they improved? Not for random arbitrary 5 or 10 feet in gait or half a muscle or a full muscle strength, but has it positively impacted that person's functional abilities and participatory capacities consistent with what they should be able to do in that unique home environment? So when we look at documentation, think about, are you looking at an initial assessment or a reassessment? They're not the same thing. Make sure you're capturing that information consistent with establishment of a baseline, setting a projected plan versus a reassessment whenever the patient's presentation requires it or when it's regulatory required, right? 60-day episode of care, 30-day functional reassessment for therapy patients. And are we going to refine and hone in and revise that program? Is the patient moving as we expected? Are revisions appropriate? Sometimes I think the best way to demonstrate skill, and Cindy, you've said this many times, is that revision of a program. We have a good baseline. We think it's going to go this way. We modify throughout. We get to that 30-day, or maybe we do it on the 20th day because the patient's not making progress as we expected, or they're progressing it in advance of what we expected, and we reestablish where are we and what do we need to continue to do that only walks in the house with us and our skill and leaves with us as our skill. Okay? And so we have to start to make sure that our documentation really is a clear picture of what we did. All right? It never ceases to amaze me sometimes that when I read OT, and I'm not picking on OT, I love OT. You know, I've never had patients get better in therapy, physical therapy, that when they meet me at the door using their assistive device, if they have one, dressed and ready for their day, having made their breakfast. Right? They've resumed those basic self-care. I don't have to go wake them up and get them out of bed at 2 o'clock in the afternoon. OT does wonderful things. But OT, let's be honest about this. When you're looking at treating these patients, you know, why is it that we want to act like we're peeping Toms in our documentation? The patient got undressed. The patient used the transfer tub bench. The patient was able to shower themselves. The patient was able to, you know, it looks like you're watching them. Think about it that way. Think about it that way. What did you contribute to make sure that they were able to do it? Okay? So the last area, before we kind of give some time for questions and answers or final thoughts, Cindy, as we wrap up, is how do we reflect this in an individualized care plan? If we're really focusing on this and we're capturing our skilled and reasonable and that it's indispensable, what about goals? Goals are a great way. In fact, it's one of the first places I look. If I can see individualized goal statements that are measurable and meaningful to that patient, then I know we're where we need to be. So here's a test. Have somebody in quality or someone in the office pull your last 5 evals, clinicians, and remove all personal health or identifying health information. Heck, just look at the goal statements. And if you can't identify why you are wanting to increase muscle strength with patient 1 versus patient 2, you're not versus patient 3, 4, 5, because I'm going to always do strengthening if I've quantified the impairment, right? And I've measured it, and at baseline it's below what it should be, and it's functionally impacting that patient. But I might work on it for 5 different reasons in 5 different patients. Capture measurable and meaningful. And remember, there are no limits on goals. Okay? And so right out of the Medicare billing manual, the only thing that was added here is the underline for emphasis. There are no rules of thumb related to restoration potential or lack thereof, ability to walk a certain number of feet, degree of stability, if we're as a way of denying a claim. We have to look at the whole picture of the patient, the unique presentation. And if all we give them is degree of stability and number of feet, then that's all they can base the claim on. So really, let's go back to our licensure. It's our responsibility. So how do we get to that? Well, I've provided some elements, how to write a SMART goal. And so SMART goals should have key elements, all right? All the professions have taught us how in our training to write goal statements. Heck, the fiscal intermediaries, Palmetto, has goal writing for dummies. I think they've rewritten it, reworded it, or titled it. But ultimately, they go back to the APTA and the AOTA and talk about the elements of how to write a meaningful and measurable goal for a patient. And so these are some guidance that you can use. And so right before we wrap, we take it back to Cindy to wrap up, let's think about these elements. And we're going to give you a couple minutes again to see if you can get to the answer of which is a well-written goal for a home health patient. A therapy patient. So just read through, be thinking about it. Patient be safe and independent with a program for strengthening for 4 weeks. Think about those SMART elements. B, patient will demonstrate improved endurance as evidenced by ability to shower independently times 2 weeks. C, patient will demonstrate a 30% improvement in lower extremity strength as evidenced by a 30-second chair stand test score that's within normal limits for their age and gender to resume ascending and descending the steps to access the bed and bathroom times 5 weeks. And D, patient will increase balance as evidenced by a score increase of greater than or equal to 4 points on the Tenetti times 6 weeks. So which do you think captures it? Cindy, any thoughts on that?
Well, I think many of them look familiar. But I think, some people have listened to this and say, well, I bet you it's the longest one, the way these ladies have been talking. I think one of our problems with goal statements is we tend to write a bunch of fragmented goals as opposed to pulling together a complete picture. And I'm not sure at what point became the obligatory, I always have to have a exercise, a HEP goal. There always has to be a goal about exercise programs on a therapy. It says who? What is the purpose of said exercise program? So I see concerns with 3 of these because they're incomplete, not because they're wrong goals, but because they're not hitting all elements of those pieces. And I think we've let pieces fall out, and then we've allowed other people to then try to interpret it. And then we get upset that they don't understand. It's like, but how can they understand when you left pieces out? It's like when you're trying to communicate with somebody, and then they go, well, didn't I tell you that? No, I'm not psychic. I can't figure it out if you don't tell me. When we leave pieces out of our goals, I think it does the same thing. It leaves them going, well, safe and independent exercise. I don't even know what they're strengthening for, but okay, whatever. I don't think that that's really complicated, and then we get defensive as opposed to, let me explain it to you.
Well, the other thing is sometimes we do fragmented goals, right? We do patient will increase strength, patient will perform this on an objective measure because we think we have to have one. Patient will be able to climb stairs. So in essence, if you look at the answer, the best written goals, according to all the elements of SMART, is truly C. And people say, wait a minute, you said we don't have to write more. Remember, SMART goals. That I can identify a patient that I'm doing strengthening on, right? That one, that's going to be very measurable and meaningful to that individual patient. But more importantly, that's probably 3 different goals the way we commonly see them written now. Increase strength, increase stair climbing, be able to get and an objective measure, right? And so that's the way things tend to be written. Look at how you write your goal statements. Realize that those are skilled professional assessments that you're making. So do them with a level of intentionality and a level of professionalism that allows you to demonstrate you're practicing to the highest degree of your license. So Cindy, I know we have a few more minutes and we might run a little bit over if there's questions, but I want to turn it back over to you to kind of wrap this up real neatly, as far as where do we go from here?
Well, I think before we leave the goal statement, though, Dee, I just want to add that the issue of goals is we don't need so many of them. We'd be better off with fewer overall that were more comprehensive than a list of 10 fragments. And I think that, that fragment methodology is what has been a challenge with our documentation. So we wanted to, with the last two slides, provide you essentially with both food for thought and possibly a tool to get us to think about what those elements are. Have we touched on homebound? It's not checking a box, but does our documentation speak to patient specificity? We've covered skilled, reasonable, and necessary. Can you look at your documentation or exchange documentation with a coworker? Can you see why it needed to be that particular discipline? What made sense about this? What made it essential? Do you see evidence of clinician judgment? I think that's one of the biggest gaps in our content is we're big on talking about patients and not about our decisioning. That's why we end up with tolerated well, progressing toward goals, as opposed to what if that area started with in the professional opinion of this therapist and then you added the rest. Well, I can't put stuff like that. Why would you not? That's what we're paid for is professional opinion, an opinion based on training and expertise, not I read a book one day and decided I had a thought. So we have to honor our own judgment. Do we see care coordination beyond left voicemail for PT? Well, for what? Did anything happen with that? We know that's a definite condition of participation issue, and I think we've hammered it enough, but can you see patient individuality? Patient-stated goals. I've never had a patient in almost 30 years as a PT ever look at me and say, I want to be able to ambulate 250 feet with a walker and standby assistance, ever. Where does that fit into their larger plan? And using the SOAP note, I know if we opened the phone lines, Dee, and decided what people wanted to say about their notes, we would end up in conference calls that went on for days because people tend to be very annoyed with their electronic medical record in particular, and argue that it's that fault, that they didn't give me a spot for this, or it doesn't let me do. Okay, first of all, whether it's an electronic tool or a paper tool, it's a tool. You're the brains behind it, not it. And I agree, sometimes it doesn't make it easy, but we have to figure out how we meet these expectations. Because subjective information, it doesn't really matter that some of the EMRs have dropped a box called that. Then we organizationally need to figure out what field are we going to put it in, because patient saying things is not just complaints. If they say, hey, I tried that and that worked, hey, that pill box you set up, man, did that make my life better. That is invaluable information in demonstrating the indispensability of what you do. Objective information, do we see it? And not just the tests or measures that may be stuck in your EMR, which overwhelmingly, and no offense to either one, tends to be the Tonetti tug. Those two are there. There are way more tests and measures available to the therapy disciplines than two. And are we utilizing them? Do we also analyze the information? Do we take our time and say what the subjective information and the objective information means through the lens of your discipline, your professional opinion, and a plan, particularly plan for next visit? Those fields very often get filled with things like Tuesday, or blank, or continue. When you speak to the intentionality of I'm going to work on this the next visit or reinforce that or talk to the daughter about, that speaks to you already have an intention. You have a plan. You're not just going because the order said, twice a week and the next visit's on Tuesday. The day is not the issue. It is you're planning ahead because you know they still need to have someone of your expertise and training following up with them. So that all comes together. So it may lay out differently in your EMR, but we cannot continue because I'll tell you the truth. When we get in trouble, no one has successfully overturned a denial by trying to blame the EMR. Okay? EMRs are working to refine things, and I get it, but in the meantime, we have to own it from that professional responsibility Dee was talking about. So we have had the Q&A box open throughout, and some of the things that were mentioned have been incorporated into the content. But if you have any lingering thoughts or questions, please feel free to take these closing moments to put that in the Q&A box. We also recognize that you have places to go and people to see, and most likely at this time of day, documentation to do. So hopefully some of those things have sparked some thoughts. I'm not necessarily convinced it makes us love our documentation, but we really want people to own it. So if you have a thought later, or if you ever hear Dee said, Cindy said, please keep these email addresses because sometimes things can get interpreted a little bit differently, and we like the opportunity to clarify and provide resources whenever possible. So we're not seeing any additional questions in the Q&A box, and that's okay. We hope the wheels are turning, and we look forward to continuing the conversation in part 2 of this 3-part webinar series. Thank you very much, and have a great rest of your day.